Hello, everyone. Welcome once again to the No CD webinar. Good to have all of you with us. And as always, this webinar is brought to you by No CD. No CD is a downloadable free app that you can get through the Google Play or iOS store. You can utilize the No CD platform for all of its various functions, from the wonderful therapy tools that it has to the awesome community of people around the world who have obsessive compulsive disorder, who support each other throughout the day. And there's also ability to do teletherapy through No CD as well. And by the end of this month, into next month, we're going to be in all 50 states, and we continue to do more and more discussions with more and more insurance companies. So we're working on getting coverage more and more. This is our Diversity Matters series, which we do the third Wednesday of every month, and I'm happy to have with us two of our No CD therapists. And I'm going to let them introduce themselves, and we're here today to talk about, lots of different things, but we wanted to take a look specifically at Central, South American, Latin American, Hispanic concerns and obsessive compulsive disorder. So Liza, do you want to go first?
My name is Liza Fernandez. I'm originally from Puerto Rico, have lived in Atlanta the last 20 years, and have now relocated to Fort Lauderdale area in Florida. And I'm practicing in both states right now.
Wonderful. Thank you, Lisa. And Maria?
My name is Maria Jimenez. I am originally from Puerto Rico too. I moved to Florida in 2012, and I lived in Colorado for a little bit, so I practice here in Florida and Colorado. Great.
Welcome. Well, as always, the chat's going to go, and we're going to let people throw some questions in, and then we'll answer some of the chat questions along the way. But I also like to make sure first that we discuss a little bit of our topic. You know, our Diversity Matters webinar series came out of the fact that we've had some experiences in our country this year that have been rather difficult, and so we wanted to make a commitment to being sure that we were going to do something to honor the fact that there just wasn't enough diversity representation in the discussions out there around mental health and mental health awareness. So we wanted to make sure that once a month we made a dedication that was something that we were going to work on. And hey, Thelma has joined us as well too. Hello, Thelma. How are you? You want to introduce yourself to everybody?
Yes, hi, my name is Thelma. I'm from San Antonio. I'm a licensed clinical social worker.
And on the No CD panel as well. And what states do you work in, Thelma? You want to let everyone know?
Yes, Texas, Florida, and Tennessee.
All right. Florida is represented tonight, everybody. There we go. So, all right. So there's a few things that I wanted to ask just to kind of start us off. And then, like I said, I'll pepper in some of the questions that we also get on the chats as well too. But number one, I think there's a lot of confusion among people, especially as we see more and more things come up on census forms or fill out what are you kind of are you this or that, are you a non-Hispanic Caucasian, are you a Hispanic? I think it confuses the heck out of people, and I'm just wondering if I can hear from the three of you, how do we work on defining what we're all from the Americas, right? I mean, but there's differentiation. So how do we work on really defining those, and what do they all really mean? What would you say? Because I'll add one more piece. You can't assume someone's Hispanic. I learned this really discussing once from someone I knew who was indigenous. To his ancestry goes back to the indigenous peoples of South America, and he said, "Well, I'm not Hispanic." So he was very confused at times about what to fill out in forms, you know, because he didn't consider himself Caucasian, but he also didn't consider himself Hispanic either, right? So it was like, is that an other or you know? So are there some specific ways that we can define what does Hispanic mean? What does Latin American mean? What how would you say we would go about with some of those discussions?
For some people, it's the area or the language or the culture. There are different ways that people might define themselves to be or not to be Hispanic or Latin. I sometimes just say I'm Caribbean. I don't need to say not even Hispanic or Latin because Caribbean. I am from the Caribbean.
Okay.
But I'm also in this melting pot of Hispanicity, Latin American person or culture.
Yeah.
For defining it, I think we don't need to define it. I think people might choose to see themselves in some way, and that's the way that they will just convey it to another person if they so choose to.
Yeah. And Anna just popped on the chat here, and I like her answer. She says, "It depends on the preference of the person," which I really like too. Right.
I agree. That's what I was gonna kind of piggyback on what Maria said. It really depends on what the person defines themselves as, and that's the way it is.
Yeah. Right. And I find it important to ask the person, right? So you identify yourself as what? You know, whether you've been living here for 5 years, 10 years, or 20 years, what do you identify yourself with? Because that is typically going to be their frame of reference.
Right. Yeah. Yeah, that's great. Anna also says it's a USA thing. Internationally, people don't say Latin, Latina, Latino, or Hispanic, which great. Thank you very much for that, Anna. That's very important for people to know too, and it's that kind of education that I like doing in these kinds of webinars, because I always tell you guys before we start that I like to ask the questions that maybe nobody else will ask because they're either afraid to ask or they think, I don't want to say it sounds offensive because I don't ever want to come across that, but they think it's not something that I should ask whatsoever. But I think some of these are important to discuss so that people feel comfortable around this, especially in the area of mental health, because we do know that culturally there are various ways that various cultures will work in the mental health area. So when we did Asian therapists a couple months ago, the idea of ever going to talk to someone outside of your family in certain Asian culture, not all, right? Because Asia is so huge, but it's just like you just don't do that, right? So I'm wondering about what is that like in, for lack of better word for tonight, Latin American, Hispanic, Caribbean, but what would you say are there cultural aspects of how you look at mental health and mental health treatment and I know it's a wide swath going from the Caribbean all the way down to the tip of South America, but what would you say are the relationships between culture and mental health across all of your backgrounds?
Well, my family comes from Mexico, so the belief is what happens in your home stays in your home. So if there is some type of mental illness, just get up and keep moving, and it'll go away. You'll get over it. Don't talk to anybody else. It's just a power of the mind, and get over it. So, and typically Hispanic men are a lot more resistant, and they keep to themselves. So I always make a joke. I'm like, imagine coming from Mexican descendants and being a therapist. It makes for a very interesting family reunion.
I bet. Yeah, I'm sure.
So it is very similar in my family. You don't talk about it.
Yeah.
It's just get up, take some tea, and keep moving.
Anna says here, mental health is non-existent in our culture. My parents have the attitude of, I've been through worse. You don't need therapy. Heck, I've been through a civil war. Just pray harder and go to church. So
exactly. Yep. And it's absolutely right.
I had two sides of it, because I remember my grandma and part of my family being very, this is in your head, there's nothing going on, or sweat it out, drop air, something like that. However, when I was in high school, I came across a psychology class. So it was kind of very early that psychology was introduced to my house, and then I introduced to everybody in my house. And for my little niche in the family, it became something that we can speak of.
Mm-hmm.
Nice.
However, not necessarily they will go to therapy if needed.
Sure.
Mm-hmm.
Mm-hmm.
Yes, I mean, I grew up in a similar way. It was, you never speak of your problems outside your family, even to professionals, even to anybody, you know, it stayed within the home. But one thing that stands out for me that I keep in mind with working with Hispanic clients is if I'm working with a teenager, even if he's 17 or 18, I feel that the family is going to be involved at some point or another more than with families of other cultures.
Mm-hmm.
Whereas some other cultures that seem to be more independent, the parents don't even know what days our therapies are scheduled, don't participate, don't want to know, aren't involved. And with the Hispanic families, even a 20-year-old will be treated like a 13-year-old, and I've got to be present and I've got to know what's happening. And so that's always a challenge introducing to them, well, you know, he or she is 18 and really there's an adult issue here. So
yeah, great, that's helpful. And then have you found it important that there are people who patients may then identify with, who can share a background, and do they report that that's more comfortable than for them to talk to someone who kind of understands, because that the person they're talking to comes from a similar cultural background?
It has been told to me, yes.
Mm-hmm.
Especially with the Spanglish, for example. Some people want just to be able to just say whatever they want to say without having to think about it, not in Spanish or in English. So they feel comfortable and more free.
Yeah. So Spanglish is a real thing. That's great to hear. I love that. That's great. I think that's awesome. Yeah.
Mm-hmm. And expression. I think they want to be able to express themselves without having to choose their words or worry that you may not understand what I'm saying. Mm-hmm. So do you mind if I say this in Spanish? Can I explain it this way? You know?
Mm-hmm. Okay.
And for me, I think that a lot of clients feel comfortable because maybe we grew up the same way, that you're not supposed to speak about mental health, you know, and the tradition. So they feel more comfortable in sharing and being open.
Yeah. And I think it's sometimes a surprise to people that we can't just assume it's Spanish either, because we have Portuguese that's also involved in a large swath of South America as well too. So that we can't even just make assumptions that, oh, you speak Spanish, because that's not necessarily the case, right? That somebody does not automatically speak Spanish either. So. Mm-hmm.
They sometimes feel comfortable too, that they don't have to try to explain their experiences growing up, because they can easily convey the message or describe what they're trying to tell me. You know, when your grandma does this and that, or when this and that happens, yes.
Yeah.
I can relate easier. Not necessarily the case that I don't know or that they cannot relate to other culture, but they just feel that connection in some way. If they feel more comfortable knowing that might be there.
Mm-hmm. One of the roles and a few of the things that have come up in the chat, so I want to kind of incorporate a little bit of what's coming up in that already into this, is the role of spirituality and religion. And what roles have you found that has played in therapy with people? Is that a common component of things that come up in therapy? Because especially in OCD, then we have scrupulosity as well too. So OCD kind of overtaking religion. And I would say that this wouldn't be a stereotype. I think that this is something that's probably believed pretty commonly, that there's a large spirituality piece in Latin American kind of cultures, or correct me if I'm wrong on that, but there's even celebrations of the dead and spirits and those types of things as well too. So how have you found, maybe working with with the more majority white clients versus working with clients who are of Hispanic or Latin or Caribbean background, that spirituality plays a role, and does scrupulosity come up differently for patients who are of that background?
I think I have found it myself with clients that it's more about what is my family going to think?
Okay.
When it comes to spirituality.
Mm-hmm.
It's more ingrained in them. So now we're not dealing with only like scrupulosity. We're also dealing with what is my family going to think of me, because so it's a lot of background too of what the family implements on the client at themselves as well.
Okay. Okay.
I have encountered, like, in the same percentage, the religious content and the need to bring the religion. And I allow the patient to tell me if that is something that they want to work with, even outside of OCD. With OCD, I just see that there are other maybe religions or beliefs that I'm not necessarily used to with the American culture, the North American culture, like voodoo,
sure,
Santeria, and things like that. That is something that I not necessarily will see a North American person bringing it as a source of their anxiety, or something that they are very keen to, and it's very important for them to have in therapy too. Because I've seen it both ways, as in an issue, or as in a source of power for them, a source of encouragement.
Okay. Mm-hmm.
Yeah, as I hear the question, I'm thinking as well, and it feels to me, I don't know if to the rest of you, but it feels to me that generationally, some of that has been lost with some of the Hispanic clients I've encountered. You know, depending, are they first generation here, are they second or third? It doesn't seem as prevalent as if it was a first generation person who recently migrated. And I wonder if a big part of that has to do, because that's who we see, right? That first generation is not likely going to be the ones that are reaching out to get help, sadly enough. But they're gonna keep their mental health issues more secretive than that second or third generation. But
Yeah.
I don't know.
Well, as we continue on here, is OCD prevalence really higher than 1%? I mean, we know about 1 in 40 people at some point in time in their lifetime meet criteria for OCD, and that seems to cut across cultures actually too. So it may appear differently in certain cultures, because certain cultures may have various different types of taboos, and OCD loves to pick up on a good old taboo. So if there's a cultural taboo, OCD will try to jump onto that, and you might not see that in other cultures because that thing just may not be a culture and another taboo as well too. Would there be various types of taboos that you have seen potentially, or intrusive thoughts that may be more prevalent among a non-white culture that if you guys encountered any particulars at all?
Got lost there.
Okay. I mean, I know in the DSM it lists like there are some different disorders that maybe come from Africa that you wouldn't see in other, or various Asian cultures might have certain types of disorders. So I didn't know if there were some more common Hispanic ones or Latin. What was it?
I think in the back of the DSM-5 you have ataque de nervios.
Yeah, they do.
Yeah, it's a nervous attack. It's sort of like a panic attack, but with a crying spell and throwing yourself to the floor like a tantrum. And, and the other symptoms of a panic attack.
Will we have therapists in the UK becomes a question. We hope to. Yeah, we're going to grow. We all want to grow. So, do any of you do much ACT work, or have a background in ACT? One of the questions, Maria, then is, how would you describe the difference between ERP and ACT?
So, with ACT, you practice the diffusion from your thoughts and you practice the acceptance of the moment, and you commit to some certain actions, and you engage, you take action towards the person that you want to be, closer to your goals, and within your values, the ones that you have identified. In the ERP, we are working on, yes, I want you to diffuse from your thoughts. I think that's very, very important. But we're going to create a hierarchy. We're going to seek ways in which actively empowering, we are going to trigger you, and we are going to work on just accepting in a way, or staying there, of just embracing that moment, staying in the present while your stress goes a little bit lower, and then we can move to the next source of anxiety or distress. Not necessarily there's anxiety, but there's the act of not doing the compulsion.
Sure. Yeah.
And what we want is that you're going to get triggered, but not do your compulsion. Not necessarily you're engaging or acting into something towards your goals or being the person that you want to be. However, that can be in your back of your head while you're working on your exercises for exposures with response prevention.
Thanks. I remember going, a buddy of mine, Michael, did a presentation when ACT was first coming out, because some of us on this panel might be old enough to remember when ACT came out, actually. And I remember listening to the presentation, and after it was done, I raised my hand and I said, Michael, I want to thank you. I didn't know that I did ACT, but everything that you described is what I do with ERP, but I use different language, right? So I haven't really found in some ways that there's a huge difference between the outcomes of ACT and ERP, and even maybe what's done. I think that there's different descriptions and maybe different metaphors and things of that nature. But I personally have found that whenever I look at ACT things, that a lot of that is exactly what we incorporate into really good exposure and response prevention therapy of, sitting with discomfort, not allowing a thought to catch on, having a thought versus buying into a thought, those types of things, and have found that to be very common for myself too. So Bentley says, I'm a gay man suffering from transgender OCD. I now worry that I'm in denial and using OCD as a front. Any tips, insight, or stories on this particular theme of OCD? I'll start with that, just to say that OCD loves to tell you that you're in denial of things. I mean, that's one of the OCD tricks of, oh, you're just in denial. I hear this all the time, especially when it's around orientation or maybe even scrupulosity. But when it's this idea that you might be something that you're not, you may feel very confident that you're not that thing, and your OCD's answer is always going to be, but maybe you're just in denial of it. Right? What have all of you seen? Anything similar to that, or?
It's just that it takes on into that space that's available there to create doubt. It's like, I'm going to get in there because it's so available. So I'm going to go there and create some doubts.
And it's fueled by the secrecy of it, right? Because this isn't something we talk about. This isn't something, my sexual orientation, if it's seen as something deviant, then I certainly don't speak of it. And that fuels OCD as well. The more secrecy that is brought into it, the more power OCD will have.
Going back to what you said, Patrick, it's like the taboo. It's like, it's true. I always hear it from members. It's like, but what if?
Yeah.
And creates that doubt.
Now, obviously, transgender homosexuality in the United States is becoming more mainstream accepted and everything. Would this be similar in our neighbors and other cultural areas, or would this still be something that would be kind of hidden in the family more so than how we're seeing it now more in the US? What do you think?
I've seen it more hidden.
Yeah. Okay.
Yes, I moved here in 2012, so it's not that long ago, and I've seen it being significantly hidden from what my experience has been in here.
Mm-hmm. Okay.
Yeah, I can give you an example. My mother still believes that doesn't exist in her country.
Oh, okay.
and she will say that, right? So that is just, I think that answers the question right there.
Well,
right?
There you go.
Yeah.
Sure.
Yeah. So generationally again, you have that issue as well of how long they've been out of their country of origin. Yeah.
Yeah. Mm-hmm. Okay. Well, that answers that. Thank you. Thank you, Lisa. that really puts a spin on there. Doesn't it? Yeah. Mm-hmm. Now, in terms of that, the second part, any tips, insights, or stories on this particular theme of OCD? Always remember this: OCD is the doubting disorder. And so here's what I say to my patients all the time: if you're gay, but your OCD now is trying to convince you, yeah, but what if you're transgender, right? No one will ever be able to give you an answer that will satisfy your OCD, because OCD is the doubting disorder. And if you have the doubting disorder, you will doubt every answer that everyone ever gives you. So if OCD sets up for you, once you get a 100% answer, I'll leave this alone, parentheses, but you have the doubting disorder and therefore you can never get 100% answer, close parentheses, then everything will be okay. So here's the thing. You will never be 100% convinced for your OCD that you're not transgender. Right. But do we have to convince our OCD 100% about something? Or can we just live with the fact that just because OCD throws this out there doesn't mean I have to pay any attention to it whatsoever?
I will encourage you to leave it.
Yep.
Yeah, me too.
I would too.
I have OCD and Asperger's. Does this make it more difficult for me to overcome my intrusive thoughts since my brain is differently wired? I don't know if it's necessarily more difficult, but I think that therapy is going to look a little bit different because we're going to have to deal with, of course, the ASD as well as the OCD as well. And Joe, if you want, we did do a Diversity Wednesday a couple of months ago on Asperger's and autism and OCD, and that is on our YouTube channel. And Kaylee in the background, hi Kaylee. Kaylee's in the background. Everyone, we all wave to Kaylee. Yeah. Kaylee can put a link up to our YouTube channel so that you can go and you can watch my interview with my friend, Dr. Maria Bontuano. And she is one of my friends and an expert in autism. And she will, she will go through all sorts of things that you can talk about in there. But that would be another piece of information that I'd be interested in. So we have the kind of more traditional concepts, I think, that many people would think about mental health of being, depression, anxiety, psychosis, bipolar mood, all those types of things. But of course, autism is also in the Diagnostic and Statistical Manual of Mental Disorders. What is the recognition like outside of the United States then in autism, and how is that looked at? Is that also seen as that doesn't exist in our country either? Kind of thing. Just out of curiosity.
Yeah.
I think it depends on the generation.
Okay. Mm-hmm.
So if you're looking at the more traditional, it doesn't exist.
Okay.
If you're looking at the younger generation, they're more aware and it's more acceptable and treatable. Like they do reach out to treatment. It's the more traditional that they don't. And I'm gonna kind of do what Lisa said. My mom is like that. She's like, oh, autism doesn't exist. It's just something else.
Yeah.
So and she's more traditional. So it really depends on the generation.
What I've seen is the combination between education and socioeconomic status.
Okay.
And in the identification, the wanting, the realization, and the seeking treatment for ASD in general. Yeah. But that's what I've noticed. Where I grew up, it was identified even in early age. I did have a neighbor and he was identified as autistic.
Mm-hmm.
So, and he was in therapy, and he was living with a very elderly couple. So it was very interesting how they were very aware, and they took this person to the treatment that he needed. And when he didn't have that, because the community lacked the resource, he regressed significantly, and so they moved.
Mm-hmm. I don't want to make any assumptions here, so please fill me in other countries, and I can say this a little bit from my own family. You know, I grew up Irish. That's how I identified. You know, you grew up in Chicago, and you were not a Chicagoan. You were an American. You were Irish, or you were Polish, or you were Italian, or you were, you know, whatever you were in our neighborhoods. But when I've gone to Ireland, I've gotten the question, why do you have so many therapists in your country? And so I'm curious, what is the number of therapists here in our hemisphere outside of the United States and Canada? Do we see a lot of them, or not so much? Or do you think people come to the US to get trained and then go back? Are there a lot of psychology schools outside of the US? I know. I do know someone who runs in Mexico City an anxiety clinic. So I know in some of the bigger cities we have it, but how is it in some of the smaller towns or the islands or things of that nature?
And some of the smaller towns, there's no therapists. Like, there is some towns that are more like mineros, meaning miners, like the people that worked in the mines.
Yeah.
And they're so small, and it's generations of families just living there, that there's no therapy. There's just typical doctors, and some of those doctors have been there for example. I grew up with something like that, and he's 80 years old, and he's still practicing.
He's still the doctor. Yeah.
He's still the doctor.
Yeah.
So that's
he
the way it is.
Your grandmother, your mother, and you. Yeah. Yeah. Right. Yeah.
Why not keep going?
Yeah.
So
yeah. Mm-hmm. Okay.
Yeah, for me, I have friends that still live back in my country, and from hearing them in conversations, it's not as accessible.
Okay.
My generation's a little more open to seeking it, but just not as accessible. However, so many of them are practicing, like in Florida, so many Hispanics. Yeah. I mean, there's it's almost a flooding of it, but they seem to, you know, it's when they leave the country has been my experience more so.
Mm-hmm. I'm so hopeful that as from what I'm hearing from you, at least, that as the generations go, that we're moving away from this doesn't exist, and so that there will be more help available to people and more openness to therapy. And more acceptance of that as well. I think that's really exciting, so that people don't have to suffer in silence so much. So that's absolutely wonderful. Let's see. Let's take a look at a few other ones. The first time I got an intrusive thought, it felt like my body was being taken over by panic, anxiety, and a realization. Is there a reason for this struck by lightning phenomena? Is it common? Well, boy, once that fight, flight, or freeze response is kicked off, it's designed to feel like you've been struck by lightning. I would say, imagine if the fight, flight, or freeze response was more of just a, you know, we wouldn't get out of the way of the car coming at us if that was the case, right? So, how do you guys kind of describe that fight, flight, or freeze experience and with patients?
It is the run for your life moment. It is, or fight. You know, it's a get active. It's the something is happening. I try to describe them as our primitive way of being, and the thing that is in our brain that has helped us survive along the way. So not necessarily it's a bad thing that you have this response. Maybe it's just too high for what's going on.
Mm-hmm.
And it seems to skip the logical thought sequence, right? It skips that and it goes right to feeling and a reaction to the feeling, and it's survival. That's the word that comes into my mind. It is survival. I can't stop and think of what's happening. I just need to survive this.
Mm-hmm.
I tell them that the space between the action of what happened and reaction, what our body is doing or what we were going to do, it just narrows it down, or even there's none. It's just action, reaction. There's no space there. So what we're working is creating a little bit of space so we can think.
Mm-hmm. Yeah, I love that, and I think that's a great message for everybody too. That idea of giving things some space, which kind of, as I was flipping through, you guys were chatting, it comes up with another question. This idea that I'm numb to OCD, I don't really get anxiety. So when I do exposure and response prevention, it feels like it's not working. What do I do about this? I've done several sessions already and I still feel the same. If I'm wondering though, if someone would be really numb to OCD, what would the purpose of therapy be? I mean, because maybe the goal, I think in many ways, the goal of therapy is to become kind of numb to OCD, of a recognition that, oh, it's there and it's saying things and I don't really have to pay attention to it. So maybe this idea that I'm numb to OCD isn't actually the truth, right? Maybe there's some other reaction going on to OCD, and that's what you and your therapist would have to really work on. What do you guys think?
Mm-hmm. I agree.
I agree. And then ask yourself, are you doing compulsions? Nope.
Yeah. Mm-hmm.
Then.
What kind of highlights are you all seeing, since the three of you are doing no CD therapy? And I have a feeling some of your patients are on here because one person said, "Oh my gosh, there's my therapist." That was exciting. But what are some of the common themes that you're seeing recently? Are there any trends going on with any of your patients, or any particular ways that you're seeing OCD appear, or anything like that?
It seems to me the same kind of themes pop up for me. The harm OCD,
Mm-hmm.
and sexual identity OCD, and relationship OCD. Those have really, just in the last several months, I have just seen that more frequently.
Mm-hmm.
I've seen harm OCD and scrupulosity, I must say, that the need for acting good or being good.
What I've seen is sexual identity, harm OCD, and relationship OCD more recently.
Yeah.
But there's a little bit of everything.
Mm-hmm.
Yeah. And it's interesting. I sometimes I have to shut people down on the comments still, because people bring something in. So someone brought in a comment but I think that it's an interesting discussion here, that this is more the influence of the devil, and if you just turn to God, then everything would be okay. But of course, that becomes a compulsion for people then, because people with scrupulosity aren't actually praying, they're doing compulsions, right? And that, I think, sometimes is a really hard thing for people to accept, the notion that this is not a religion problem. This is an obsessive compulsive disorder problem. Mm-hmm. If it was a religion problem, then yes, we would tell people just to pray, right? And we would say, if you could just say the right prayer at the right place at the right time, everything would be great. But when you have scrupulosity, you almost can't even say the right prayer, right? Because then you think you made a mistake in it, so you have to go back and say it again. And I've had people who have prayed for hours and hours trying to get it just right, just perfect, because in their view of scrupulosity, God would never accept a non-perfect prayer. To which my answer is always, well, then God only accepts perfection. And if God only accepts perfection, then God only likes God. And if God only likes God, it really doesn't matter what the heck you do, because God doesn't like you because you're not perfect anyway. So you're kind of screwed from the beginning, right? And then people are like, you know, they don't like that idea. But it really is true. You know, you've got a disorder that's telling you that you have to become perfect in order to be accepted, when you are an imperfect being, and therefore are never going to meet the standards of perfection. Plus, just because you think you're perfect doesn't mean I do. So now you've got to be perfect for 6.5 billion people who live on the planet, all at the same time. So how have you guys kind of gone about, because all of you mentioned a little bit about scrupulosity there and the intrusive thought piece. So do you have any great nuggets of wisdom on scrupulosity and treating people who have scrupulous concerns?
Well, one thing I always like to talk about with when someone is stuck in that prayer and not being able to stop is, you know, I encourage them to always try to figure out, is this something I need to do, or is this something I want to do? Right. So if it's a need, we need to look at that a little closer. If it's something I want to do, then it should be easier to walk away from, right, and not have to engage at every moment. But if there's this intrinsic need that they cannot fathom not completing, then we're going to lean more towards treating it as OCD and teaching them the difference between those two things.
Mm-hmm. Yeah.
The things that are long, like the rosary, for example, it's a really long sequence.
Sure is. Yeah.
And so I try to break it down. You know, let's try to break it down, minimizing the amount of time and just playing with the idea that what's the difference between one prayer, 100 or 1,000?
Yeah.
Is he hearing or not? Is he omnipresent or not? Do I have to stay here and pray that many times? Like you say, it's a want. Do you want to? Can you then? Or do you have something else that you need to do right now? Or you want to do? I see people that needs to go to prayer instead of engaging in the next activity in the life, even if it's a leisure one. But then there's something that is not right that tells them that they need to stay and pray.
Yeah.
I explained like what you did, Patrick, like earlier you said, it's always going to be that doubt. It's a disease of self-doubt. So you pray and you pray, but then is that going to be enough? Is there a doubt of, did God accept that? Or was that good enough? So like Maria said, it's just kind of trying to resist and just kind of prolong it a little bit more and wait a little bit more. But I guess we all got trained the same, right? Because it's about actually just identifying, is it something you want, something you're choosing, or is it something that you feel like you need to do?
Yeah.
And the other thing that they are sometimes engage in this prayer because they think they're going to prevent some really radical thing or something bad that is going to happen. Then let's go and say that thing bad that is going to happen. Why don't we say that thing bad that is going to happen? Let's write that down. That thing bad that you think is going to happen, and just diffuse, you know, make that disconnection between the thought action fusion, you know, just because you said it, just because you think it's not going to happen. And just because you pray for it, doesn't going to prevent it either.
Yeah, you brought up one of my favorite things, thought action fusion, right? That thinking something is not as bad as doing something, right? So, yeah, absolutely. And then Nancy brought up that, of course, you can have scrupulosity about morals as well, too, right? It's not just a religious scrupulosity, that there is a moral scrupulosity as well. What if I've offended someone or done something unethical? But remember, and I think all of you will kind of notice this, that all of these start with two words, right? And those two words are what if, followed by the worst case scenario. You know, no one with OCD's ever walked in my office. I don't know about the three of you, but no one with OCD's ever walked in my office and said, Dr. McGrath, what if everyone loves me and thinks I'm awesome? You know, we've never treated that one before. No one's had that as their obsession, or by any means. It's always awful, horrible, worst case scenarios. And I liked what Matt said earlier, I'm going to pull that up just to show everybody. Matt says, you're right. I haven't done anything bad before, and I had like a million of these thoughts before OCD. The chance is small that I'm going to do something now. And yet I sometimes liken this to the movie. Have any of you seen the movie Dumb and Dumber?
Mm-hmm.
Okay. So there's that scene in Dumb and Dumber where he's talking to the girl and he's all attracted to her, and he wants to know if she'll go out with him. And she's like, I would only go out with you if you were the last man on earth. And his response is, so you're telling me I got a chance, and that's what I look at OCD like. OCD is Dumb and Dumber, right? It's this idea that, well, hey, as long as there's a chance, this should be something that we should really be focusing on here, right? And so really paying attention to is this idea. And are we willing to accept the fact that we have a chance? And I always say to people, we accept the chance that every time we get in a car, we could die in a car accident. And we accept the chance that every time we, turn on the grill, the propane tank could blow. Or, there's so many chances that we accept every single day without giving 2 iotas of crap about them. But then we decide, but in this one area, this one thing, I can't have any doubt about this thing. I'll accept all sorts of doubts about everything else, but not about this thing. And if I could just not have doubt about this thing, then my life would be great and wonderful and everything would be just awesome. And it doesn't work that way. It just doesn't work that way. So,
and I feel that fear that OCD loves to tap into, that fear, like you shared earlier, Maria, about, am I a good person or not a good person? Because at the end of the day, what that means is, am I going to be alone? Am I going to be rejected and be alone? And that fear is so great in our culture currently that we're really dealing with. And some people truly are isolated and really facing this. So that has been exacerbated by what's going on. And so I think us addressing and understanding that underlying fear and why OCD loves to kind of, it's fertile ground for it, is beneficial to understand as well, which fuels, am I good? Am I bad? And why that becomes such a daily torment.
Yeah, I have seen that core belief or the core fear of being alone or being left alone.
Yeah,
being rejected by their peers or their family,
or society in general.
Yeah. A reminder to everybody out there, once again, this is the No CD podcast, No CD, downloadable free app through Google Play or iOS, and teletherapy. And here's an amazing example of 3 of our teletherapists right here with me tonight. Thank you. Thank you all for joining me tonight. I really do appreciate that. We've got a few more minutes left, so continue to get some of those questions in, and we'll go on them. What about when the reality is a physical health symptoms? Well, whether reality of something or not, physical or mental health symptom, none of it really matters, because OCD will throw it in the grinder of OCD and chop it out into its worst bits possible and get you to believe the worst case scenario could potentially come true, and then want you to think about that for the next maybe 73 years or so, if that's a possibility. So I don't know about you, but here's one of the phrases I use, especially for people who have a lot of physical health issues. I'll say, will you like to spend the rest of your life sitting next to your tombstone, wondering when you will be 6 feet under it? Or would you like to spend the rest of your life running around, having a great time, partying like a rock star, showing up on the day of your death at your tombstone, with a boa and a martini in your hand, saying, damn, that was a great time, right? Now, I'd like the second one. I don't know about any of you, but I think OCD prefers the first one.
Yep.
Absolutely.
It's almost like fun is not allowed in OCD, because then you're letting your guard down. If you're letting your guard down, then something bad happens, right? So how dare you let your guard down and enjoy yourself and have a good time? because then you're just opening up to the fact that something bad could actually happen. And how dare you be so reckless with that? We see that a lot in, say, post-traumatic stress disorder as well, too. People who've been through a trauma then who are always on guard all the time, looking for the next bad thing to happen. So this is kind of a common theme, really, among anxiety issues, where we're always looking out for something horrible. When you have panic, you're always scanning your body to see when you might be experiencing that next symptom that could become the heart attack that you think this time it will be, even though all the other times they were panic attacks, right? But of course, this time's not going to be a panic attack. It's going to be the death of me. It's going to be the heart attack. So if we're constantly on the search for something that's going wrong, how do we find anything other than what's going to go wrong? Or how do we focus on anything other than what might go wrong?
Yeah.
Are there so I had made that comment earlier about prayer because somebody was going off on that. I had to remove them. But someone just wrote, pray. Yeah, right. Pray for a new brain. That's what I like that. Any advice for calming down the paranoia or panic feelings that come with OCD? Want to throw anything out there?
Yeah, it depends on the context. You know, you might choose to do some grounding to calm down from a very high level of emotion experience in the moment. You might choose to do some grounding to stay present, but to create that space in your brain so you can think what's going on. I sometimes try to tell my patients to describe to themselves what's going on, or if they know that this is OCD, if they have identified it already, then talk to OCD and tell OCD what's going on. Mm-hmm. Tell them, describe what you're going through so you can put it out there and you can create a factual base of what's going on. Mm-hmm. Stop being so emotional and or stop being so personal and starts being more the OCD thing is that thing. And, mm-hmm. and you can then try to create that or put in place those tools that you have acquired through life and through time and through therapy. Yeah. But I understand there is a moment of panic, and in that moment of panic, maybe you want to describe it to your OCD and talk to it.
I like that. Talk to your OCD. That's kind of fun. Mm-hmm. Yeah. Because it's talking to you all day long, right?
Right.
Yeah. Hey, look out over there. Ah! You know, all these things. So our talk back could be, shut your face, you know? Yeah. Mm-hmm. Yeah. Or I don't care what you say. I'm going to move on. And which is always a good one. Yeah.
You're such a trooper, always here with me.
Yeah. Yeah. Exactly. Yeah. Thanks for the great advice, by the way. Yeah, really appreciate it. Yeah. Mm-hmm.
And if the paranoia is about, is it going to show up? Let's be clear, it will show up. So we don't have to be paranoid about it. We know it's going to show up. It's what are we going to do when it does, right? So we don't have to be paranoid about it.
Yeah. Yeah. You know, sometimes people with anxiety-based disorders and OCD almost act as if they're shocked every time this thing happens, right? Yeah. Lately, I've been describing it actually like Charlie Brown and Lucy and the football. And Charlie Brown is shocked every single time that Lucy pulls the football up and he goes flying through the air because she pulled up the football and he crashes down on the ground and he's like, oh, foiled again. And if there's anything we ought to know, every single time Lucy is going to pull up the football and Charlie Brown is not going to kick it. And yet he, again, is just surprised as all get out that it happens when it happens. So I love that idea, what you say there about it's coming anyway, so why be surprised about it? I think that's fantastic. I love that very, very much. Mm-hmm.
Setting realistic expectation is important. And some of the other things I use too is regulating emotions. So being able to build, like, okay, a little bit of what Maria said, like, what is your wise mind? Okay, what is really happening, to be able to ground yourself. And if the emotions get too high that they can't regulate them anymore, using some ice, it helps regulate when they're becoming too overwhelmed to a point of maybe crisis, if you may.
Mm-hmm. And then eventually we could try to turn some of those feelings into exposures too. We could try to expose people purposely to those situations. So, you know, for panic, what's the best treatment for panic? We use interoceptive exposure. We have people run in place and hide, or spin in a chair and breathe through a straw and do push-ups. And we create all of the symptoms of panic to teach people that they don't need to be afraid of panic anymore, that panic symptoms aren't dangerous or anything like that.
Well, one of the things I use is that if it's becoming too much for them, to do quick exercises, which is also a kind of an exposure. Just do quick exercises, get your heart going, and it helps them as well, but it's an exposure.
Yeah. Matt says this, what do you guys think of this? I got scared that I always am going to do something bad today, or thought I had an urge to do something bad, but I never did. My brain then obsessed on that event. Matt, I do know that I have to go... I do know that I have to go out to the store tonight. So my plan will be to run over 3 people in the parking lot this evening while I am at the store. So that's going to be my plan. Would any of you like to also offer up some urge or thing that you might do this evening as well? Anyone? Anyone?
Sure. The next guy that cuts me off on the road, I'm going to ram my car right into the back of them.
Thank you very much, Lisa. Yes. How about Thelma, Maria? You want to offer some things you might do to somebody?
Well, there's a pool party going on. I think I might drown somebody.
Excellent. Drowning someone in the pool party. Wonderful. Thelma, yeah. What are you going to do?
I think next time my husband gets me mad, I'll just end up punching him in the face.
There we go. There we go. A good punch in the face to that as well too. So we've got 2 car related, 1 pool, and a punch in the face. I like that. That's great. Thank you very much. It's all on tape, by the way. This is being recorded, so now we have that. So that's good too. So we're all aware of this, and hopefully we all kind of recognize, joking aside, that those are just very common OCD types of things. But all of us on this panel now will have those things in our head as well, too. And just because we have them in our head does not mean we are going to go and do them as well. So, well, we're a couple minutes out. So I just want to give each of you a minute to say any final words, and to thank you also just for being on this panel to bring out this idea of, as I'm very interested in the cultural experiences of OCD and mental health, and I appreciate all of you for joining me for that. So I'll give it over to each of you if you have any final words.
I want to thank for the invitation also, and I like the fact that this is out there and that people can just be integrated with this process, and it being live and just there for the community. That's it.
I think that, you know, one last word I'd like to leave with is that we all are Hispanic. We all have our different cultures. But don't make assumptions, right? When you're working with a Hispanic client, ask them. Don't be afraid to. You know, you gave birth and you're not allowed to leave your room for how long? You know, is this a cultural thing, or is this a mental health issue? You can't take your baby outside because it's dark and that night air is bad for your baby. Is that a cultural thing, or is this right? So do not be afraid to ask and not to make assumptions, because I think all of our cultures have a history of beliefs and superstitions, and we just should not be afraid to ask and get more information when we treat clients from other cultures.
Wonderful. Thank you very much. Thelma?
I also want to thank you for inviting me, but I also want to say that too, that as a client, I want to tell the clients not to be afraid to ask questions as well to their professionals, not to be afraid and assume as well about their counselors. And as counselors as well, as what Lisa said, is don't be afraid to ask, okay, are these really hallucinations, or is this religion, or is this cultural of the beliefs? So just for both client and the professional to not jump to assumptions and be empowered to ask questions as well for the clients.
That's wonderful. Once again, everyone, thank you for joining us for the No CD webinar. No CD downloadable app available on Google Play and iOS. Utilize our community. It's with people all over the world. We've got teletherapy now in all 50 states within the next month, where you get more and more insurance panels available. Great therapy tools also on the app. We really look forward to working with all of you. We don't want anyone to have to suffer from OCD anymore. Thank you, everyone. And big thanks to the three of you. I really appreciate it very, very much. Good night, everyone.
Good night.
Good night.